Thanks, Harish, and I'm a bit embarrassed to realise that that prize was over 40 years ago. Actually, it wasn't in 1980. 1980 was when I started medicine, so this prize was in 1984. But still, it's way, way too long ago than I'd like to think about. Look, if I think about some of the things that I think are really important for success in any careers, and that includes for people who are interested in health careers, but I actually think it's in anything. I think it's this notion of be involved. I'm a clinician, I'm a paediatrician, I still see adolescent aged patients typically in their secondary school years. And I'm forever saying to kids and encouraging them to participate and talk about this notion of learning by doing. And I think it's only by doing things that one experiences options, you learn about yourself, you learn about what you like, and you learn skills in doing so. My sense is that it's put your hand up and say yes rather than say no. But it's also those skills of hard work, persistence, and luck. So I'm reminded of the Greek aphorism about the Greek goddess Athena. And Athena was the goddess of luck and fate and good fortune. And the aphorism goes, together with Athena, you must lift your own hand, by which I interpret that to mean that, you have to work hard, but you also need to be lucky. And that notion that, you make your own luck is something that other people I've heard talk about that. And I think the lucky person in life is the person who's able to see a lucky break and acknowledge it for what it is and sort of really run with that opportunity. I remember my fourth year exam, actually, where you take me right back all those years ago, Harish. But I remember my exam, and as I was led into the exam by a young resident who was supervising the fourth year medical exams, and he made this comment to me about the patient that I was about to see, and he just quietly said, "Don't forget to ask him about the bottle." And I didn't quite understand what he meant at that time until I realised when I started interviewing the patient, which was that he was an alcoholic. And I don't know whether, if I hadn't have had, if you like, the luck of that resident or intern sort of just making that lovely, gentle remark to me as I went in, I don't know whether I would have scored quite so highly in that examination. But no doubt the fact that I knew all about all of the side effects of heavy alcohol use enabled my hard work and my study to then shine in that situation where it mattered. And I think that, so I think it's recognizing that, luck favors the prepared mind, is that the other phrase? But I came across, just last week, this wonderful quote from Nelson Mandela that I'd never heard before. And Nelson Mandela talked about apparently, I never lose. What he said was, I never lose. Either I win or I learn. And I've been reflecting on that for the last week and thinking about me, commonly talking about how for my patients, you need to learn by doing and put your hand up and say yes to opportunities rather than being fearful and saying no. So that notion of either I win or I learn, I think is a really lovely thing for others to reflect on as well. I think this is just as relevant for adolescents as it is for any other age group. And perhaps just to put this into perspective, our research group has demonstrated major variation in what we call the burden of disease. So if you like, premature death and disability in adolescents living in the poorest of countries in comparison to those who live in medium socioeconomically advanced countries to those that are the wealthier countries. And so those adolescents growing up in poorer countries have much, much higher rates of death and much higher rates of disability and chronic illness as well. So that pattern is certainly true globally. And we see a similar pattern in adolescents growing up in Australia, so that young people who are growing up in poverty have far worse health outcomes. Now, we know that poverty disproportionately affects different populations, immigrant populations, Australians growing up in rural and remote areas, homeless young people who have been in contact with the justice system, and Indigenous Australians. So we know that there are particular populations who are at greater risk of poverty. And many of these populations of young people can be thought of as, in a sense, being on the fast track to adulthood. They're more likely to leave school earlier. They're more likely to engage in adult behaviours at an earlier age, such as substance use, such as early onset sexual activity. They're likely to take a greater set of engagement in risky behaviours in their life. And so it's no surprise that poorer adolescents have higher rates of substance abuse. They've got a greater likelihood of living in unsafe environments and being exposed to high rates of interpersonal violence. They have higher rates of early parenting, which affects then the next generation. Higher rates of suicide, reflecting poorer mental health, and greater rates of obesity. So for a whole lot of health outcomes, they're poorer. And then that, if you like, is only then compounded by the fact that their access typically then to interventions is less than in wealthier populations. So that young people who are poorer typically are growing up in more disadvantaged families who also have less knowledge about how to access the healthcare system, for example, are less able to pay for health services that might only be available in the private system. And then those who are in more geographically isolated regions, almost by definition in Australia, have poorer access to healthcare and have generally the quality of many health services is less than in the capital cities. And it's interesting because if we look at over the pandemic, where there's been, as you would all appreciate, a huge shift to telehealth, I think many people initially thought that telehealth might be a mechanism of helping to overcome some of these inequities, at least in terms of access to healthcare. But in my experience, telehealth does promote access to health care for people in more regionally remote areas, but by no means is it a panacea to overcoming those inequities of access. If only that the bandwidth is typically poorer, that we really struggle to engage with people with poor bandwidth on telehealth, and that people are less likely to have the sort of quality access to care where their even health providers have, say, video telehealth versus just a telephone. So slightly complicated, but for every reason we know that adolescents who are growing up in poorer households have much worse health outcomes. What a terrific question, Harish. If you'd asked me a few years ago, I would have been much more perhaps critical, because within the Millennium Development Goal era that oversaw global investments through, led by the UN, the primary goals around children were really around reducing under 5 mortality, so that was MDG 4, reducing maternal mortality, MDG 5, and promoting universal participation in primary education. And even though so MDG 5 of reducing maternal mortality was highly relevant to young people because early parenting is a feature in so many low and middle income countries. Within the Millennium Development Goal era, adolescents were basically invisible. They were not a major priority population. And even in HIV, so MDG 6, Goal 6 around reducing HIV mortality, where we know that 50% of new HIV infections are in the 15 to 25-year-old age group, that there just really hadn't been a visibility that was brought to adolescents. But fascinatingly, over really the last 3 to 5 years of the MDG era, where we were moving into what became the Sustainable Development Goals, there became a much stronger focus on adolescents, virtually from every organisation within the United Nations. So that in that 5-year period, we saw major reports published on adolescents, related to adolescents one way or another, by UNICEF, by the United Nations Population Fund that typically focuses on sexual and reproductive health, and by WHO, that were all really quite helpful at trying to, in a sense, build momentum so that there was a greater orientation to adolescents and their healthy development in the SDG era. But I think it's also interesting to recognise that it's not just the UN alone. And so currently WHO and UNICEF and UNFPA would be the lead agencies, but UNESCO, that sits over schooling, is the other major organisation. But I think it's not just these agencies alone, and I would really like to highlight here the important role that academics also play in influencing the United Nations. And so at the University of Melbourne, our own research group was involved in a series of global publications, or globally relevant publications, that really brought attention to the health of adolescents in ways that really the UN agencies had not previously done. And indeed, all of these reports that I've mentioned in the lead up to the Sustainable Development Goals cited this work that we had led through the University of Melbourne. And some of the ideas that the Lancet Commission on Adolescent Health that our group published, for example, some of the ideas from those academic pieces have been hugely influential in the current UN system, including WHO and UNICEF, in terms of really helping to now continue to drive new investments. And so part of that thinking is in relationship to this notion of what we call the triple dividend. And in the Lancet Commission that was led by George Patton of the University of Melbourne, that I was also very involved in, we talked about this notion of investing in adolescents to reap the benefits of a triple dividend. So when we get investments in adolescents, right, we have firstly healthier adolescents, so fewer of them dying from suicide, for example, or road traffic accidents, or from HIV/AIDS, the first return on the investment. The second return then on that investment is when adolescents grow up to be, as healthier adolescents, they grow up to be healthier adults. And I always use the example of tobacco smoking. So that for most young people, if you don't smoke by the age of 18 or 19, you're not a smoker as an adult, and becoming and not smoking as an adult is one of the healthiest decisions that you can make in life. And then the third return on that investment, and I think this is perhaps where we've been most influential, is recognising that adolescents are the next generation to parent. So just like I talked previously about this notion of the fast track to adulthood and how damaging that is for young people's current and future health, it is equally damaging in terms of the health of the next generation, because young people who parent early are then less educated because typically they've completed school earlier. They are typically poorer. They are growing up in households that are typically poorer. They're going to be less likely to breastfeed their children, less likely to want to immunize their children. And mothers in those households often have less power within the family dynamic to make the sorts of healthy choices that they themselves would inherently like to make. So that notion of, if we're really interested in getting a healthy start to life and reducing under 5 mortality, which had been one of the major targets within the Millennium Development Goals, the appreciation that that investment can be expedited by continuing to be investing in adolescents themselves, I think was a really major influence to the United Nations agencies that was achieved out of that academic publication or a series of publications in the Lancet. But if I would just make one other comment, which is that one of the challenge within the UN system is that they haven't brought visibility to adolescents. And in part, that's because they've used different language and different terminology. So they've referred to, and the different agencies have variably referred to children. So UNICEF refers to children as being under the age of 18, and up until a few years ago didn't use the language of adolescents or young people as well. It really singularly used this language of children. WHO has got a different definition. It defines adolescents as 10 to 19 inclusive, so under 20, versus UNICEF, which is under 18. And they typically had referred to adolescents. But then the United Nations Population Fund typically referred to youth, and they then had a definition of youth being 15 to 24. So the fact that they used this different language and different age definitions, and the other thing that we, I think, achieved in the Lancet Commission was having a stronger appreciation of the fact that there is an increasing upward age, so that adolescence typically isn't actually finishing at 19 or 20, even as was first defined by WHO in the mid-60s, but actually adolescence extends through to be inclusive of young adulthood into at least the mid-20s. So this period now of adolescence and young adulthood being from 10 to 24 is what we now describe. And I think there is the quiet appreciation within the UN agencies of really appreciating this need to be breaking up that adolescent and young adult age period into 3 broad groupings of early adolescence being 10 to 14, later adolescence being 15 to 19, and then young adulthood being 20 to 24. And my sense is that we in Melbourne have had a really pretty important role in terms of contributing to those debates. And they have been debates around how we define this developmental span and what we call it. Harish, you couldn't be asking a more important question about this sort of interface between schools and health. And I'm sure for all of the students who are listening to this, you can probably yourselves reflect on how your own schooling has affected your health and well-being in different ways. And I would certainly just, use the example of bullying, for example, because we know that students who are bullied, particularly girls, have a 3-fold increased likelihood of depression and anxiety 12 months later. So schools have got an incredibly important role to play. But it's really interesting because there was a very famous, well, he still is alive, British psychiatrist, Sir Professor Michael Rutter. And 40 years ago, Michael Rutter did some amazing studies in the slum environments, or the very impoverished environments of inner London. And he and his group asked the question about, they were interested, well, to step back a minute, they were very interested in the impact of poor socioeconomic circumstances in terms of health outcomes. And their interest was in asking the question, to what extent can schools modify or bolster or protect the damage that is otherwise accrued from impoverished social circumstances, poor environments. And so his research group worked with a number of these schools where the overwhelming student body was a disadvantaged student body. And I think one of the important things that they were firstly able to demonstrate was that there were differences between schools. And so there were some schools that were really able to make a difference and other schools that didn't. And so they then started to try and understand, well, what is it about these schools that can make a difference? And I think that these studies that were very old studies, as I said now, have been strongly influential of a number of people's ideas about the importance of schools, not just as settings where you might, if you like, run a health promoting program, but where the school environment as a totality of everything that happens in a school community, where the students feel safe at school, physically safe, emotionally safe, whether they are engaged in learning because the teachers are making learning fun and interesting and finding ways of engaging students in ways that make them feel more connected to their school, to their teachers, to their peers. This is still a field that we're learning a lot about. Our own research group recently has been involved in developing the first global standards for what WHO and UNESCO called health promoting schools. And health promoting schools is an idea that's been around for over 25 years about this sort of notion of how the whole school environment can be making a difference. And there's a lot of currency now, and we only have to stop and think about the impact of school closures from the COVID pandemic and impact then in terms of student emotional well-being to appreciate that there's something very positive about student participation at school, as well as potentially the negative opportunities that can come when students don't feel engaged, when they don't feel academically successful. So I think that the challenge for us in health is to think much more widely about schools as communities and how can we recognise that, yes, educational curriculum, let's give the example of sexuality education, really, really important in terms of making sure that all students have an understanding of the basic building blocks of what it is to be sexually healthy, to make sure that students know about what contraception is, the risks of sexual intercourse without contraception, what is sexually transmitted infections are, the value of being able to access health services, things like that are all of the sorts of things that might be embodied within sexuality education in a curriculum at school. But really, so much of the health benefits, as I see it, that accrue through schools are much more in these intangible relationship elements between students and teachers, within the school as a social community. And that is still an area that we are really learning about. How do we measure that? How do we change that? How do we influence that? And this is where it seems to me that the students who are listening to this, you guys are the experts here, and I would be really encouraging you to be owning your voice and sharing it with your school leaders about what you feel you need in your school communities to feel safe, to feel engaged, to feel empowered, and to feel that schools are a place that you really want to be participating in, and that you're learning, obviously, the sort of skills that you really feel matter for you. And I wish you all luck in that endeavour.